That was very, very interesting talk, and we have to remember, KISS, keep it simple. But, you know, and it kind of reminds me of when I, all those hundreds of years ago, was in college and doing rehab engineering. The Prinky Romage, one switch, if you can move anything, if you can wiggle an eyebrow, if you can blink your eye, you can control an environment, which is kind of our CART facility here and what our OTs do a lot of. It turns out that there's no doubt a role for ever improving assistive technology in the classic sense and assistive technology in the not so classic sense, and capitalizing on the newest technology. And that's what this afternoon we'll learn about for the people who can't, no matter what, control their environment because they've lost the ability even to necessarily control eye movements or eyebrow or hands at all, and to be able to, in a very complex way, control an environment and communicate. It's going to be pretty breathtaking. You know, one of the things I'm very happy about today is that we've got a mix of industry and academia moving into industry, and industry supporting academia, and learning from one another. And I think, too, that it's very nice that we have people from all over the country and all over the world so that we can pool our efforts. I will tell you one thing that I personally am engaged in with Dr. Montez is that we're looking at robotics for children with cerebral palsy and now children with, including actually already children with brain resections for epilepsy. And we are going to be able to accrue that data much more quickly by leveraging resources. So we have a small NIH grant now to collaborate with Indiana University in Indianapolis and with Blythedale Hospital in New York. And I'm hoping that today will make new friendships and trusting bonds so that we can collect pilot data more quickly, whether it is the role for different types of manipulations, be it robotic or not, for recovering spinal injury, for stroke, etc. So Dr. Edwards is on the faculty of Cornell Weill School of Medicine in New York. He is at Burke Rehabilitation Hospital, which is where I used to work many, many years ago. Burke has always been a leader in neurologic rehabilitation, more in stroke than I dare say in spinal injury, but with Dylan at the helm of this, I'm sure it's going to explode very fast, and there's going to be all sorts of new things, and we hope to collaborate with him. Anything else I need to tell them about you?
That's right. Thanks.
Okay, welcome.
So we might need to dim the lights a little at some point. Thanks for inviting me. It's a pleasure to be here, and I've really enjoyed the lectures so far. I was thrilled to be allocated this topic, not because I have immediate expertise in data, but because it's an area that I think is really exciting and that I'm launching into. So I don't actually work with exoskeleton robotics, but I'm poised to start actually. And so what I thought I would do is, I have a background in I was a teaching professor with tenure in Australia, in Perth, where some of the little dots on the map we saw in the last presentation. And I was teaching in human motor control and clinical neurophysiology. I went and did a sabbatical at Harvard Medical School, and I was really excited to come and work in the US actually. So I took a job at Burke Cornell, and I still work at Harvard Medical School. In fact, I'm going to Boston tomorrow, and I hear there's a big snowstorm. I'm teaching in a course there this week. I was very interested to start working in the robotics program with Bruce Volpe and Hermano Krebs using the IMT upper limb robotics. And subsequently, working on this full time, I was successful in a couple of back-to-back NIH-funded grants looking at robotic upper limb training in stroke patients. So I'm not completely green in this. I do have a reasonable amount of expertise now in the upper limb for stroke, and I certainly think it has a lot of merit. Today I'm going to talk about the lower limb predominantly, and both stroke and spinal cord injury from a perspective of motor control. And I think it's a very important time because in terms of rehabilitation robotics, and we need to distinguish between assistive technology and rehabilitation technology, my principal interest is to get people using the remaining neural substrate that they have themselves. So I need to really distinguish between these two things. I think there's a lot of merit in assistive technology, in the brain-computer interface controlling robotics as well, and completely bypassing lesioned neural systems. That's not the focus of this talk, so I need to highlight a couple of really important things for you, but please bear in mind that at all times I'm very much in favor of robotics for the non-modal learning aspects, for the psychosocial aspects, the improving quality of life. So I've been involved in a couple of projects. I consulted at the Goodman Institute in Spain, and they have a Locomat system and a bodyweight supported treadmill trainer. And you know, I've been around to a few places now and observed people on these devices. And also I've worked as a therapist for a while. I was a private practitioner while I was teaching at university as well, and so I've seen people moving limbs around, and I've seen machines moving limbs around, and I think that one of the most striking things is that as you're watching this, it looks pretty impressive, and everybody standing around and says, "Bravo, this looks great," and the loved ones of the patients are impressed. But as a scientist, I'm critically analysing whether this is having a positive translation to the person being able to use their systems themselves after this process. And I believe that there is merit in doing it, but we really need to pay attention into what we're doing. So I don't think it's automatic. I think if we just push limbs around however we do it, and we're not paying attention to some very important things, then we're not likely to see improvement in function voluntarily by the patient. So I've got no real bias. I think that therapists do a great job, and machines can do a great job as well. There's advantages to both, and certainly I like the appeal of the robotics, and I really think it has a great future as a complementary tool in therapy. I have no particular bias to any of the devices, actually. I think that, you know, a lot of the devices are quite different in their way they operate, but they have merit. So let me talk about some of the things. This is an exo device, and I have no experience with this either, but I was invited to the Scripps Institute a couple of days ago, and I saw this in action with Dr. Lovatz and Dr. Stone. Let's have a look at this video works. So of course I'm highly excited to see this kind of robotics, and we've seen some more this morning as well. And as I said, I haven't really got a position on any of these devices yet. I'm still getting my mind around how they work and how they might be beneficial as a rehab tool. So things that I notice are that the foot is pretty much passive. I mean, there's springs on this. This is a person with complete paralysis from, I think their injury was around about lower thoracic level, a spinal cord injury patient. Long term after their injury, and they've used this device a number of times, but they're getting full movement of the legs, obviously. The ankle is pretty much is passive in this, in that there's no actuators at the ankle in this device, and so it's just springs, I guess, that hold it into dorsiflexion as the foot comes forward. So to me, that's one important aspect, and the actuators, I guess, are at the hip and the knee. And then there's a little backpack on the back as well, and quite a lot of control comes from the arms. So I think this has potentially got merit. Certainly as an assistive device, I think these things are fantastic. As a rehab tool, probably needs a little bit of work, but there's some things that could be beneficial that I'll talk about now. a little bit on my background again, so you can see the perspective where I'm coming from. This is the clinic that I have at Burke. As Mindy said, she was formerly at Burke, so has experience with this lab. Dr. Bruce Volpe has done a lot of the pioneering work with Ego Krebs, who you can see in the picture here. And so we have a pretty busy clinic that runs every day, and I don't run it. I have great staff that run it. Avril Rickman here is the OT that's responsible. And we're doing upper limb robotics in these chronic stroke patients with a residual upper limb deficit, and they come in for 36 sessions. And so we're about a year into a 5-year NIH R01 grant, and we're actually looking at whether the TDCS, brain stimulation, can be good as a supplementary tool to this robotic training. And we have some very, very promising preliminary results. For those who are interested, that's how the study design looks. So I think most of us, based on these papers that are coming out with the well-controlled studies, the VA study in the upper limb in stroke, showing that this kind of paradigm here, 36 sessions over 12 weeks every other day of 1 hour, they alternate between shoulder and elbow one day and then they do wrist the next day, leads to relatively important gains in function. Actually, it leads to important changes in the fugal myome. And so on this basis, the American Heart Association for Stroke gave this Class 1 level A of evidence. So and actually our data suggests that we get at least that benefit, if not more. And so I'm interested to see whether we can get more benefit by applying the brain stimulation. But let's talk about the lower extremities, because this is an area that I'm quite interested in, and I think is at a really pivotal point in rehabilitation robotics. So you don't need to convince me that the autonomic benefit, the orthopedic benefit, the psychological benefit, and the reduced burden on the therapist is very, very impressive by these devices. So I think just on that basis alone, I would probably have one of these devices and offer it to patients in a clinical situation. And as certainly as the cost comes down, that can be a really, even with the present cost, it could be a plausible option. What I'm really wanting to talk about today is this aspect of it, the motor control benefit. So if we talk about rehabilitation robotics in the lower limb, so improving gait in stroke patients or spinal cord injury patients, is it having a positive benefit? I would say that the success of a rehabilitation robotics program isn't limited to these things, but these are two very, very important factors. The ability of the patient to contribute to the training and to the movement is a very critical factor. As well, the ability of the robot to encourage the desired repetitive muscle activity is a very, very important factor. So essentially, and we've actually heard this already this morning, if we want rehabilitation robots to be successful in improving human voluntary control and translating to when the robot isn't being worn to them having better function, then the patient had better be contributing to the movement during the application of that robotic therapy. And for that, they need to be attentive, they need to be motivated, they need to be getting feedback about how they're performing in these other aspects. And then a bit of the onus back on the companies. The robot really needs to be encouraging the desired, and it has to be a repetitive, as we know, dose is very important. And that's one of the reasons robotics is good, because it can deliver a high dose. It has to be encouraging the desired repetitive activity. And so I think we need to give a little bit more thought to that. So I helped this group at the Goodman Institute in Spain publish a paper. They had a look at quite a large number of spinal cord injury patients that they had that were participating in, they do quite an intensive inpatient therapy stay, where the patients stay for about 8 weeks and they get daily therapy, and that includes this gait training. And they were putting people on the Locomat or the bodyweight supported gait trainer. And so that was really my first experience with this. This looks a bit like an exoskeleton as we saw before, but they're on a treadmill, and there's some loading down onto the treadmill, but the bodyweight supported. This is the gait training device, and the feet are in they're kind of fixed at the end point, and they go through the movements with less or with no individual joint control at the hip and the knee. So kind of a different method of operation, really. When they looked at how the patients changed in the clinical scales that they felt were important and gold standard, lower extremity motor score and a walking index and a 10-meter walk test, the purpose wasn't really to compare which of these robotic devices is better. In fact, there was no other control. They were just looking at the change in clinical score, and it seemed like, you know, regardless of which device you were on, you experienced this change in a positive change in function over time. So this was really my first exposure to this, and I thought, well, it doesn't tell me that one device is better than the other, that even that gait training is good, because it could have been the other things they're doing in therapy that was causing this change, or it could have been some degree of spontaneous recovery. But it did show me that that at least it was well tolerated, and practically it could be easily incorporated into standard therapy. And so I thought that therefore, you know, I'm not sure that you would embark immediately on a controlled trial as to whether this is effective, and in fact, this has been done and has got kind of scathing reviews so far. But to me, it showed some merit that potentially these could be potentially beneficial. So I'm going to get back to that in a second. First of all, I thought what's important for us to do is to define what a robotic device is, because I think not only is it murky for lay people, but I think it's murky for us as professionals. So I work with robotic devices, and I review papers and grants about robotic devices. And for me, it's still a little bit unclear. So I'm wondering what everyone else is thinking, what is a robotic device? And I've just pulled these things off the internet. You know, which of these things are robotic devices and why? Well, they're all involve some electrical motor and powered system. You know, we've got this little passive movement device up on the left. We've got a complicated exoskeletal device. We've got like a Biodex system, an isokinetic dynamometer that you find in exercise physiology labs and motor movement disorders clinics. So I've thought that, you know, we have to provide a definition for it. This could be one definition of what a robotic device is. So an intelligent powered exercise machine that might involve a visuomotor or functional task performed repetitively. So visuomotor, I'm thinking of the MIT Manus robot that I use, where they're watching a screen and they're trying to hit targets based on their arm performance. Or it could be a functional task like walking in one of these exoskeletons. Potentially it should sense a patient's capabilities and provide suitable assistance. So it should be somehow listening to what the person is doing and providing assistance accordingly. It should potentially reduce the assistance as the patient improves. And it should provide feedback. And the feedback, what I guess I have most experience again with the MIT robots, but they have both what's in the motor learning literature. You have two types of feedback. You have knowledge of performance, which is the ongoing, how well am I doing, what position are my limbs in kind of feedback, which is critical. And you have knowledge of the result, which is, did you achieve the outcome that you wanted to? And I guess the IMT robots try and do that by giving you real-time visual feedback about accuracy. and also stopping after a series of repetitions and saying, this is how well you did in the last block, this is the score you got, you know, your accuracy is improving, your range of movement is improving, etc. So that could be done in many different ways, but ideally, rehabilitation robotics should have those characteristics. If they don't have that, maybe they're just a passive movement device, or maybe they're an isokinetic dynamometer. And you might have different ideas, and please tell me in question time if you think. So somebody who wants to embark on using rehabilitation, using robotic tools as a therapeutic option, I'm very concerned when I see papers like this. Very, very concerned. In fact, those of you who are at the American College of Rehabilitation Medicine, the American Society of Neurorehabilitation in Vancouver recently, you know, this was brought up in Bruce Dobkin's talk, and I guess to a group of professionals, the papers like this and those kind of presentations could really kill the field of using these robotic tools as a therapeutic option. Not an assistive device, but as a therapeutic option, because it's reported that the trials that have been done to date are very disappointing, and they're not seeing a translation into improving human function. And so when I see that, I don't take away the message that robots are not good for improving human function. I think of it as the way we're using these robots to improve human function in people with neurological injury is not optimum at present. That's what I think about. That's how I think, how can we make them better? What can we do differently to make sure that when people are using these therapeutically, that we do see a translation into a clinical effect. So I'm still very optimistic that we can use these devices in a positive sense, and I'm planning to do so actually. But if you look at the available evidence to date, the way they're presently being used therapeutically doesn't, there are some trials that show merit, but the largest body of evidence is not pointing in a positive direction for the use of these things as a therapeutic tool. So I want to raise a few points that I think I would like to address to make these better. One is one that I heard last year, actually, that David Renkensma spoke about, if I heard correctly, this concept of slacking. And this is something that I've observed, actually, with the upper limb robotics, and that is where you have external support or assistance, it's just human nature that you tend to do less. So I just came up with this continuum. At one end we've got no support over here. At the other end we've got like a rigid brace. This is an example of the ankle. And somewhere in the middle you might have robotics or springy devices or stretchy tape. And here we're just showing that when you have no support, during practice it'll be maximum down here where you have the rigid brace and minimum here where you have no support. And the amount of muscle control required is minimum down here when you have a rigid brace and maximum up here when you require no support. So at what point would a positive response to practice be expected? And I would have thought that it would not be the case where you have maximum support because you don't need to do anything. It would be the case where you are required to use your own muscles in a meaningful way. So the point is that the more support you're providing or assistance you're providing, it's a dilemma because the person is naturally going to want to do less. The second is promoting unwanted activity. And I don't think this is well addressed at the moment. And I just use this as one example from some literature, but there's other examples as well. If you push a limb around, if you push a limb in a given direction, the natural response for the muscles that are controlling that limb segment is to resist that. It's a reflexive reaction. So here's an example just from one paper, and as I said, there's many others, and it can occur at many different angular velocities. But if you suddenly push the hand in that direction, the biceps is going to respond not only spinally, but transcortically as well. So at all levels of the neuraxis, you have this resistive response to that movement. And so when I think about these robotic devices that are grabbing onto a limb segment and pushing them in a certain direction, the natural body response to that is not to move in that direction, but in fact to move in the opposite direction. So we had Dr. Harkamer come out and talk recently at our institute, and she was saying that this is one of the reasons she doesn't use robotic devices, because they prefer to actually put pressure on tendons and muscles when they're trying to facilitate muscle activity rather than just pushing a bone. And the practice makes perfect conundrum is the third point. So if you have a high level of skill, even in elite athletes, you still need to do perfect practice. So even an elite, a healthy subject, you need to be really focused on doing all of the elements of practice that are important. You need task specificity, repetition, maintain concentration, really doing perfect practice. You need the feedback, and you need to progress from that. So what I suggest is, as you move more towards paralysis and away from high skill, the person becomes less able to practice well. To the point where if they're completely paralyzed, you're just moving the limbs around. So perhaps there's an optimal range for who's going to respond therapeutically to robotics. Somewhere in the middle here. I mean, maybe people who are very high, who are at the higher end of function, they don't need a robotic device, they can just be doing functional tasks. Maybe it's best for people who are in the middle here. And these people who are completely paralyzed, well, that's a different kettle of fish, I think. And we need to really pay attention for this. Are we going to somehow spark up these circuits just by moving these people's limbs around? That was the original thought. Well, maybe we can if we use supplementary stimulation or other techniques. So this was a pretty profound paper, actually, and if you see the video, yes, it is impressive. So potentially we shouldn't disregard using robotics in those people who have absolutely no function. But I wouldn't do it. I wouldn't embark on a clinical trial to see whether it works or not. I wouldn't waste my time or money on that. But I might think about doing it if I had some other tool that would prime the system and enable it to fully engage during that robotic process. And this would be one example in spinal cord injury. And in fact, a colleague in Australia, Byron Koukoulas, he studied these like well over 500 patients, cadavers actually, and showed that even in really, really traumatic spinal cord injury, it's very, very seldom that you have complete transection of the cord. And so usually there are spared fibers, which means there is some descending control. It's just not enough to engage those hopefully relatively normal and healthy spinal circuits below the level of the lesion. And we're just about to put out a paper in Spinal Cord showing that if you use transcranial magnetic stimulation, actually you can identify these pathways as well, even in patients that have complete motor paralysis. What about for stroke? And this is like the second last slide, and then I'll finish. Well, I'd like to use robotics in the lower limb for stroke, these exoskeletal devices. Whether you do bilateral or unilateral training, I mean, that's an open question, and I'm not sure the answer to that. You would think that unilateral would be, intuitively, I'd think that it's probably better because they have a unilateral deficit. But certainly if you have the ability to generate asymmetric control with one of these bilateral exoskeletons, then that could potentially be beneficial as well. The fact that we have no ankle control yet in this device, although I think that it's coming, is a bit of a concern for me if we use it for stroke, given the foot drop is, one one of the predominant problems. But if they can overcome that, I think that could be quite useful. The ankle bot, I'm pretty excited about starting to work with the ankle bot, and I think that I will. They show that this operates around the ankle, and they argue that most of the gait, the forces for gait come from the ankle, and we know that it's a very important joint in terms of gait disruption after stroke. And they say that if you have this ankle bot here, it's relatively low weight and it doesn't affect normal gait pattern. And they show that preliminary evidence in stroke shows that they can improve kinematics and gait speed with seated training, not with standing training. Okay, so to summarize, and then I'll finish. What are robotics? I think we need to be really careful that we, as consumers of the literature and contributors to the literature, define it very well. Are they assistive devices or rehab devices? You don't need to convince me that as an assistive device, they're fantastic. And I think that I will absolutely be promoting that. As a rehab device, I'm not convinced that we're there yet for the lower limb. And I think the literature supports that. And I absolutely haven't given up. In fact, I'm even more excited to get into it because I think it's a ripe area for funding. And we can really make a difference. Whether to use exoskeletons or like these end space robots requires a little bit more intellectual thought, and it might be to do with the nature of the patient and the deficit. Why is lower limb robotics getting a bad rap currently? I think for a few different reasons, because we're not doing it well enough, and maybe if we can select our patients carefully and select the type of training that we're doing and adjust these robotic devices very subtly, we can have a profound difference on the effect that we get. So how would I use them, and how am I going to use them? I would like to be able to maximize what the patient is doing at all times in these robotic devices in real time, and at no point allow them to lose concentration and stop participating and activating those muscles that are really important. I've watched some brain injured patients on the Locomat, for example, and they're not engaged at all. They're just looking in the other direction, but the limbs are moving around. The clinicians are all applauding, and I think it's we need to really move on from that. So engage what the patient's doing it all the time. Ensure that there's feedback, constant knowledge of performance. Whether to train function or impairment, this has been an ongoing debate in physical therapies for a long time, and I'm not sure whether, like the ankle bot, you just train in sitting position, the ankle, foot dorsiflexion, and that translates into gait, or whether to try and incorporate that same action actually during the gait cycle and the practicing gait. I'm probably going to do both for my research. I couldn't predict which one of those will be more effective. And certainly overload, I think, is very important, that it's progressively increasing in difficulty. In which patients would I select? I think the patients with the best function are going to be the ones who can participate in training the best, and so therefore they will be more likely to have a positive response to that training. I'm not giving up on patients with very, very low function, because I think it's an incredibly important group to deal with. And that we can potentially help these people as well, but we need something else. I'm not going to be starting a study just applying these devices to these patients and expecting that things are going to be different, because we need something else as a primer or something to augment that response. And there's a number of people I work with who both interstate and international, and I think I've used up all of my time, so I'll say thanks very much.
I have a question. Is it possible that we're measuring the wrong, or looking for the wrong results in our studies? For example, I used an arm robot, and I found that I got a tremendous benefit by being able to raise my left knee immediately after using it, and it's been functional ever since. So is it possible that if we're just testing arm function, we wouldn't see the result, but there are other bodily results that might demonstrate the efficacy of the tools?
I think so. I think in my world of soft research funding as my livelihood, I have to be, and also just to make sure that the field moves in a direction that it needs to, we have to be very hypothesis driven. So sometimes you find these kind of ancillary effects, and we do, believe me. I mean, we're seeing speech improvements, and we're doing right upper limb motor training, and I didn't expect to see that, and so now we're formally assessing that as well. But we need to be really thinking about how we're going to, what do we want to change, how might we best change that, and then set up rigid scientific hypotheses and test them. But I think there are ancillary benefits as well that are very interesting.
Well, thank you for a really interesting, thoughtful approach. It could be argued that Burke is where robotic rehabilitation was born. Back in the day when Ego Krebs was a graduate student, and most of the people he mentioned, Fletcher McDowell, Bruce Bowlby, they've all retired and moved on, and he's the next generation of people looking at robotics.